I'm really delighted today, though, to introduce a dear colleague and an LCLI fellow, Sunny Anand. We decided to focus on Sunny's work in Memphis around decreasing disparity because of what Gary mentioned, what's going on in the world right now, the Black Lives Matter movement. It's long overdue. It's something that I hope and I pray will really result in long-lasting substantial change. But the violence against all sorts of folks, back and forth, verbal and otherwise, the political rhetoric and divisive tweets that are coming out of certain places, unfortunately, it's wearing on all of us. It's stressful. And I think it's also particularly poignant in terms of our brothers and sisters of color being hit so much harder by COVID than some of us in terms of both suffering and illness and mortality. To me, it really does speak to all the leading causes of life, but particularly it gives us hope. It's agency for something that can be done pretty quickly. Most of us that work in the medical or the healthcare field know that it usually takes what they say to get from bench to bedside. It usually takes sometimes upwards to 16 years to actually be tested, vetted, proven, and then move into clinical practice as a standard. Dr. Sunny Anand is a physician, is a professor of pediatrics, anesthesiology, perioperative, and pain medicine at Stanford School of Medicine, University of Oxford, and was a Rhodes Scholar there doing his doctoral work, and then completed the advanced medical studies in the United States at Harvard Medical School, Boston Children's, and Mass General. But most important about Sunny is that he's a man of great faith and compassion. My favorite story about Sunny was when he was at Methodist in Memphis. The folks that he worked with in the ICU, the staff, the colleagues, the parents, the children, the kids that he worked with, and the babies, they had a nickname for him that I think sums it up. Because of his compassion and gentleness and kindness, they called him Dr. Love. So, without further ado, we will turn things over to Dr. Sunny Love Anand. So, Sunny, welcome. Thanks for being with us.
Thank you, TC. This is really the most loving introduction I've ever had.
I doubt that.
Yeah. Can't say much after that. This is something that we do in the pediatric ICU. We look at our observed mortality rates. And then based on the severity of illness, we have really good algorithms where we can say what is the expected mortality rate going to be. And so when I reached Le Bonheur Children's, I did this analysis. This is what every chief of critical care or PICU medical director does within the first 2 weeks of getting there. And I saw that our observed to expected mortality ratio was 1.89, which was totally unacceptable. The best PICU in the country at that time had an observed to expected mortality ratio of 0.55. So, there were 45% less children dying than were expected to die in that ICU. But in our ICU, it was completely the opposite. There's 89% more children dying than were expected. And so what are the underlying causes? Now, I hate to say this, but this is sort of traditional epidemiology. What are the underlying causes of death? And so what turned out was that our ICU in Memphis had a very high mortality rate amongst children from Hispanic families, Hispanic and Latina families. And that was quite surprising. It was, in fact, 3 times higher than either African-American children, which is the majority of our population, because 68% of the Shelby County area is African-American, or the Caucasian, or the other, ethnic racial groups. So this was very, very, this was really shocking and totally unacceptable. So we discussed these results in the, various ethics committees. TC and Gary helped bring this to the system, the healthcare system that we were part of in their bioethics forum. We talked to the Senior Leadership Council at the hospital. We had a quality council in which the CEO was the chair. talked to the entire physician staff, residents, fellows, nurses, respiratory therapists, whoever was willing to listen to the story. And we said, we've got to fix this. We need to launch some things really urgently. So within 6 weeks of getting these results, we had put in motion what was to be the very first multi-level healthcare delivery intervention at that time. Up until then, there were about 150 papers showing disparities in healthcare and outcomes, but there was nothing showing other than some policy initiatives that were being considered at the state and federal level. There was really there's nothing that empowered people locally to, find local solutions. And that's what we needed to do. We could not wait for the federal government. So that's how this whole story started. Our first sort of stop, this was in December 2009, was to educate all the healthcare professionals about culturally competent care, about what are the values, what are the practices in Hispanic Latina families. It took some education. We connected with local leaders and community reps, in various parts of the city. But what also became clear to me was that we need to have more bilingual staff, because there are nuances. There are things that get lost in translation. There are facial expressions, non-verbal communication that is misinterpreted. A simple sign like this can mean, wait a minute, or can mean, an abusive thing in different parts of the world. What happened was, our CEO was Mary Armour. She was a former nurse, and so she empowered her chief nursing officer and our PICU nurse manager, and we got about 7 or 8 bilingual nurses, so that there was 1 or 2 at every shift. We also, because I was chief of critical care, recruited faculty, recruited fellows. We had multiple residents who came by saying they're willing to help. We then made a proposal, and it was finally funded, for having 24-hour interpreter services available in the emergency department and the pediatric ICU. Up until there, interpreters were only available from 8 to 5. So all of this happened in November and December 2009. The next thing, starting the following year, 2010, we translated all the consent forms, all educational materials, pamphlets, websites. The website was a much delayed thing. It was later in 2010. But we also, I also realized when I did an analysis as to when these deaths are occurring and who's the attending on service at that time, there was a pattern that emerged. I made a proposal in our group and said, whenever we're having end-of-life discussions, we need to have a palliative care consult and a palliative care person in the room with an interpreter, just so that we have one other sort of set of eyes and ears, participating in the empowerment of life, in the connection that we're trying to establish with these families. Children who were arriving with critical illness to the emergency room were had a higher acuity, were more critically ill than was. So it was obviously a question of healthcare access. So we went to the mayor's community council and made outreach efforts. I personally went to 4 Latina churches and talked to the pastors and people over there. And we got help from the city government and the local health department. The Tennessee Shelby County Health Department made available mobile vans, made available immunization services, all those kinds of things. And if I may share my screen, we saw a drop in the mortality rates for Hispanic children within 1 year. By the end of 2010, we had already made a difference. By 2011, there were no statistically significant differences. The results were obvious because we were looking at mortality rates every 3 months to see if this intervention was becoming effective or not. From a threefold higher mortality, we were like 1.3 or something like that, not statistically different. And in 2012, there was really no difference. In fact, this graph was tweeted a few thousand times by various people in the pediatric community. And it really showed that local efforts, local champions can alter the health equity environment in their areas.
That's amazing, Sonny. And having been a little bit on the cusp of that work, the rapidity with which those changes were made and the lives that were saved was just amazing. And how you engage stakeholders across so many different areas and